Next talk will have the surgical management of obesity. I'm presenting Professor M.Jaber, who is the head of Department of Upper GI at Wollongong Public Hospital, and he's a specialist in bariatric, hepatobiliary, and esophagogastric surgery. He's also senior lecturer at the University of Wollongong. Please welcome Professor please welcome Professor Jaber.
Thank you, Khaled. Thank you very much, and good morning. So once again, that is all right. Good morning, everyone. It's always a privilege and an honor to be here. That is my fourth time presenting over 4 consecutive conferences, and every time we discuss this, it's always rewarding. So far so good. Education, exercise, medications, waiting, but really, are we delaying the inevitable here? So people may go through that pathway 2, 3, 4 years before they're getting referred to a surgeon. Are we truly aiming at avoiding the surgical consult, or are we actually just denying and delaying the inevitable here? Short answer to that is yes, conditions apply. We know that it's delayed referral worsens outcome. We know that sometimes medical treatment fail and obesity is progressive. That's how they became heavy in the first place. And we know that the problem so far is 2/3 of the etiology is wrong genes and 1/3 is wrong discipline. So whether education, exercise, medications, or an operation, we all here trying to give them a hand with their own poor discipline, so hopefully they can get over the problem, which is 2/3 of the etiology, not their fault. Going through that, we tell the patient up front from the first minute that we do have what we call a prediction sense from the first minute of the interview, and I tell them that always the secret of happiness is in the right expectation. So when they come with a BMI 40, although we push them the same way to diet and exercise and try some medications pre-operatively, post-operatively, but we tell them up front, you have to be realistic, i.e. a patient of 80 kilograms can well try without an operation, and our duty is to protect them against having an operation. But a patient when he's 140 kilograms, thinking that Wegovy is the way to go, full stop, they need to be educated from the first minute that this not gonna happen. So an operation is the main cornerstone of the pathway, and that's what we need to talk about. So when to refer a heavy patient, more than 40 BMI, or more than 35 with comorbidities, failed medical treatment, highly motivated patient that they really want to be healthy for their age, etc. But when not to refer. So far we said that is a problem in discipline, isn't it? So if the patient has no control whatsoever on their discipline, i.e. intractable psychiatric illness, despite optimization by a psychologist, psychiatrist, not able to go, then they cannot have an operation. Or when the operation is too risky, pregnancy, end-stage liver failure, decompensated cirrhosis, portal hypertension, etc. Or when it's not worth it, cancer, or multiple issues, significant heart failure that they cannot really come to theater. But we do know as well that this group, they are poorly compliant to start with, whether active substance abuse, heavy smoking, alcohol, etc. We can wait on them. There isn't any rush. We can wait on them, hopefully, after a prolonged rehabilitation program, with the help of physiotherapists, dietitian, MDT consultation with other specialties, they may come to the main road, and so we can help them with an operation. And we know that the MDT is very important. So we always send referrals to cardiologists, endocrinologists, all the involved specialists of the patient to decide if we can go ahead or not. Now we agreed, for example, that we need to do an operation. It's like any other operation. There is nothing called book you, get you done. As a prerequisite, and sometimes they get annoyed with that, they have to lose 10% of their preoperative body weight, 10%. And that will help us, to discover that they are willing and disciplined, and also to improve and reduce the intraoperative morbidity complications, postoperative morbidity and mortality. Smoking, substance, alcohol drinking, that is not negotiable. That is certificate one, they have to stop all of that. And if they can't stop it, then that is a huge X in the first interview, which as if they may not proceed ahead. And doing a gastroscopy is very well recommended in all of them. It is recommended in sleeve gastrectomy, but it's a must as a preoperative for bypass. Actually, failing to do a gastroscopy before a bypass is not covered medico-legally should the surgeon miss a cancer, for example, or something in the stomach. And gallstone symptomatic biliary disease need to be sorted before the procedure. So there is actually no rush. Now, that is for the next few slides. What operation to choose? Rule of thumb, simply, what operation to go first to, the reflux of the patient determines that. So the first question to them, do you have long-standing bad reflux? Answer is yes, they have to go for Roux-en-Y gastric bypass, full stop, regardless, unnegotiable, because all other operation will fail. We know that sleeve gastrectomy is a refluxogenic operation. Make them refluxing, we will understand in the next slide why. And we know that Roux-en-Y gastric bypass is an operation that is first described to treat reflux people, but then they notice that they start to lose weight. That's why they labeled it as a gold standard after that as a weight loss surgery. So heavy reflux, Roux-en-Y bypass. No reflux, medium diabetes, reasonable BMI, they go for a sleeve. So sure, if they are just heavy but not super obese, they may have a sleeve gastrectomy. So the indication for a sleeve gastrectomy is as simple as that. BMI more than 40 or 35 with some comorbidities. And nowadays, even a BMI 35, if they're very motivated and they tried conservative management, couldn't help, then they need to go for that. So a simple thinking is a BMI, I would say between 35 and 45, no reflux preferably, or very low reflux, and it's a simple surgery. So they get a sleeve, and that is not an exaggeration. That's what they need, and we tell them that you may acquire a reflux, and we write it in the consent, and if you have a mild reflux, may become worse. However, we use a sleeve as well as a bridge when we have a hugely heavy patient that doing a bypass is so risky. We sleeve them as a bridge. Hopefully they lose 40, 50 kilograms, and then we reassess. Maybe we can do as a step 2 a bypass operation, and definitely to avoid insignificant reflux, Barrett's or hiatus hernia. Avoid sleeve, remember, avoid in reflux. Why reflux? Is a simple plumbing principle. We're cutting 2/3 of the stomach, and we leave a third or a quarter of the stomach, which looks like a sleeve, hence the name. So you can imagine that's a long column of fluid, simple plumbing, then the pressure will be high. Even a no reflux patient will acquire a reflux in some 30%, and a mildly reflux patient will become much worse in half of them. So I do significant reflux questionnaire, and I write all of that down. And if I discover that they're mild, we can consider sleeve, otherwise we'll move on. So if they have a history of large hiatus hernia, history of Barrett's esophagus indicating long-standing reflux disease. Reflux for the last 20 years, for example, not a sleeve. Even if they're only 85 kilograms, if they're only 38 BMI, for example, they should not have a sleeve. Then we consider a bypass. What bypass? And we said that it is a Roux-en-Y gastric bypass. Now, I know you're all excellent at visuals, but there's some two differences between a mini means one joint. Mini means easy, one joint, that's the thing. So, two differences. In the Roux-en-Y gastric bypass, what do we want? We want no more reflux. So, we treat all the hiatus hernias to start with, suture them, and then we make as short a pouch as possible. Why? Because the acid production is in the distal stomach, mid-stomach, parietal cells, so hopefully there's not much pouch remaining to release acids. And what else? We bring a meter from down below, or that is an alimentary limb, so the food will go there, and guess what? We get another meter to join it all the way down, that bring bile. So no bile will go to the esophagus, i.e. no biliary reflux, and no acid productivity, so no gastric reflux. Good for reflux, and that is the way to go. Whereas a mini bypass, as you can see, there shouldn't be a reflux problem to start with. So the aim is to make the pouch as long as possible. Why? Because when you bring only a loop, see the bile will come all the way here, and some of it will go to the stomach. You don't want the bile joint to be here, then the whole bile will go up, which is a technical mistake. So as long as possible, and we suture it in a way that the bile will go there and hit all the way down, so it doesn't go up. So as you can see, the stomach does not know the jejunum from before. Unfortunately, it's an arranged marriage, so hopefully they love each other afterward, but we try to make them able to do so. Remember, loss of bile coming to here, remember ulcer here. Ulcer is less here, we still see it. So if the patient is too heavy, we go for a more prolonged procedure, which is, we believe that, say if they have BMI 60, for example, we do 2-in-1, a sleeve and a bypass at the same time. But here, we don't call it a drainage operation. It's a bipartition operation. We bring the ileum up. This is a sleeve ileal bypass. The sleeve can drain in two ways. Therefore, mild reflux is good because this is a good drainage operation with that regard. And there's less micronutrient deficiency as there's a long loop before they go to the colon. It's the best missile against heavy morbid obesity. And the last variety of the bypass is SADI procedure, where you do the same as a sleeve, but you bring the duodenum, you cut at the duodenum, slightly more morbid, I would think, and we use it as a revisional procedure, or rarely. So in summary, the Roux-en-Y for reflux, if there is a medium patient, big diabetes, no reflux, mini bypass is reasonable. Heavy patient, big diabetic, mild reflux, SADI or SASI is the way to go. So quickly about complications. So I have never put a drainage in any operation because if they leak, they do not present during the admission. They go home, they have fever and sepsis, they come back and we detect a leak, which is manageable nowadays endoscopically. If they bleed, however, although this is not your problem because it happens during the same admission, they're so obese. They don't show the clinical signs of bleeding. Typically, they encourage to move, they go to the bathroom, they faint. That is typical of intraperitoneal bleed, otherwise you can't tell it. When they call me like that, CT scan, theater the same evening. And for the last 15 years, I have one bleeding, and it happened in the Easter day and was a struggle to find an anesthetist. So this is important. So any pain after bypass is an urgent referral, and may happen 6 months, a year, etc. Gallstones need to be excluded. ulcer is the major cause, but internal hernia need a laparoscopy. So any pain undifferentiated, a few months after the bypass, urgent referral back to the surgeon, and we often offer a laparoscopy to exclude internal hernia so we can fix it. Smokers are the subgroup that we struggle with that. I think we almost band, as you can see, I have never mentioned band because I've removed hundreds, inserted none. So band will ruin the esophagus, will ruin the upper stomach. We remove it, wait 3 months, and once again, a bypass. Stricture is always ischemic. We have the help of our gastroenterologist, dilate, wait, try to treat. Otherwise, we have to convert to a revisional operation. We cut all together. So last couple of slides, dumping syndrome, we see it. And that is important. We think it's rare, actually. I do see it in my practice, especially when I operate on cancer. People do total gastrectomy. So early dumping is more common than late dumping. It's basically an osmotic phenomena. They eat lots of sugary stuff, and they flush it with the fluid, and osmosis, pain, diarrhea, they get better. Or they have delayed dumping, where they really become hyperglycemic, then insulin surge, hypoglycemia. They feel dizzy, sweaty, and they typically lie on a sofa on the floor for a few minutes. They get better, and that is a referral back to endocrinologist. Resolution of metabolic syndrome, the more complex, the better resolution in general. So more malabsorption, better resolution. That's why the best resolution with the complicated stuff, least resolution with the sleeve gastrectomy. Hence, the selection is very important in the first place. Weight regain, we see it 10 to 30%, mainly in people who have lost their discipline once again, or due to technical factors, as Dr. Ahmed mentioned, dilation of the pouch, for example. So nutritional deficiency, once again, the highest malabsorption, the highest nutritional deficiency, but with adherence to post-operative plans and revisions, that is under control, actually. Follow-up is a multidisciplinary once again, and is every few weeks to few months blood tests, vitamins every day, exercise, and dietitian review. And that's it. So I feel that surgical intervention is safe and effective. Early referral, multidisciplinary approach, and ongoing adherence to team is the way to go. Thank you very much.